3, 2, 1, go. Well, hello, everybody. My name is Jan de Waele. I work in Ghent, in Belgium, the Ghent University Hospital, and it's a pleasure and an honor for me to participate today in this online event, this workshop on antimicrobial TDM in critically ill patients. I'm sure that many of you are busy in your ICU with COVID-19, but I do think it is important to continue our efforts also in other domains and work on antimicrobial use, improve antimicrobial use, in which antimicrobial TDM, I think, is an important part. These are my disclosures, none of them, in fact, relevant for this particular presentation. Now, I don't think I have to tell you about the heavy use of antimicrobials in our ICUs. In lots of situations, this use is, in fact, inappropriate, unnecessary, or suboptimal, and quite often the dose may have to do with this. Clearly, there is room for improvement, and this is why we've been focusing on antimicrobial stewardship in the past years. And I think it's very important, before I go into detail about the role of antimicrobial TDM in the ICU patient, TDM is an integral part of this stewardship approach. I think it's very important to consider that TDM should not be used as a standalone tool. It's of little use if your initial dose or your initial choice is actually the wrong one. It's very important to remember this throughout this presentation and probably throughout this meeting today. Now, while we have slowly implemented TDM of antimicrobials in many patients, the strategies we use around the world are quite variable, and any formal guidance until recently was lacking. So what happened in clinical practice? Well, we used different approaches in different institutions. We learned, we gathered experience, and everybody more or less went their way, creating a lot of variability, different thresholds, different targets being used now in institutions around the world. Now, this is, of course, also caused by the lack of strong clinical data, studies looking at hard clinical endpoints. So while from a physiological point of view, there's a lot to say in favor of TDM, we do have to realize that up to now, it has not been demonstrated to be advantageous when looking at hard clinical endpoints for many of the drugs that we use it for. So this is why these four societies, the European Society of Intensive Care Medicine, with ESCMID, with the International Association of Therapeutic Drug Monitoring and Clinical Toxicology, as well as the International Society of Antimicrobial Chemotherapy, have joined forces and set out to develop a guidance document for TDM of antimicrobials in critically ill patients. And this is what I would like to talk to you about today. So this guidance document that was published earlier this year in Intensive Care Medicine was an international effort specifically focusing on the critically ill patient, which was an important and actually also quite unique feature of this project. And now in the rest of my presentation, I will guide you through this position paper, discussing the most important aspects of it. It is available from the website of the journal, and it was endorsed by these different societies involved. So the approach used actually included a review of the relevant literature, logically, of course, with a focus on critically ill patients. There were a number of face-to-face meetings that were organized, and different sections were covered by different groups. This was followed then by discussion and drafting of recommendations, after which these different recommendations were scored by the panel. And this is what I will show you at the end of this presentation today. I don't think I have to spend much time on why TDM may be relevant for this particular audience. I think you are fully aware of the effects of critical illness and the resulting variability in antimicrobial concentrations for many of the drugs we commonly use. This figure shows you just the different mechanisms involved, but the bottom line is that concentrations vary considerably, can be higher concentrations, can be lower concentrations. I'm sure you know this. So clearly, TDM, on the other hand, is not a new thing in the ICU. We've been using it for many drugs, typically when drugs have a very narrow therapeutic toxic index. So the main reason to use TDM in the past was to monitor for potential toxicity, and I think it's still very important. But an important consideration now is that we've been moving from toxicity to efficacy as the primary reason for performing TDM in critically ill patients. Now, still, toxicity, of course, is important. Don't get me wrong. But clearly, the efficacy now trumps toxicity these days. And this has become particularly relevant in the era of antimicrobial resistance, of course, where you need higher concentrations, and specifically the efficacy is of primary concern. You need to have these adequate concentrations if you're dealing with borderline resistant or even maybe resistant pathogens that you are treating. So when we look at antibiotics, it's clear that for the different compounds we use in the ICU, all the boxes are ticked here. All the criteria that should be present to allow for reliable TDM actually are present for antimicrobials. There needs to be significant pharmacokinetic variability. Yes, absolutely. There is an exposure range associated with response, whether it's toxicity or efficacy. Yes, absolutely. There have been sampling time points have been identified. Yes, and accurate and timely assays are available. And also here for many of the drugs we are using, yes, assays are available. There may be issues, and I'll come to that in a minute, but assays are absolutely available. So when we look at sampling, there is a number of ways to sample the patients when you do TDM. Of course, depending on the strategy you use and the drug you are administering. The most well-known strategy, of course, is measuring the minimal concentration just prior to the next dose. And this will provide you some information on the clearance of the drug. Another strategy is to use multiple samples. It's a little bit more complex, but will allow you to get the information such as the area on the curve, the time above the MIC, can all be calculated. In fact, 2 samples can already be enough in this so-called limited sample strategy. It does require you to use dosing software, but this can be enough to make adequate estimates of a number of pharmacokinetic variables. And finally, and that's probably the easiest thing to do in patients receiving continuous infusion, you can, of course, sample at any point in time after steady state has been reached. You can sample the steady state concentration of the drug. Now, the assays available for TDM are, of course, an important aspect. We would require assays that are accurate and precise, that's logical, but also that have a fast turnaround time. It's of no use to do TDM when you get results only 2 or 3 days later, like you would normally get for an MIC. It's only logical, of course, that validated methods are being used, which is not yet the case for all antimicrobials. And of course, these assays should be covering a broad range of clinically relevant concentrations as well. Of course, you know that some of our antimicrobials are protein bound, and it would be preferred, or the ideal situation would be to measure free concentrations, but in reality, this is too complex, and we have to stick with total concentration, and we just assume or hope that the protein binding is more or less comparable in different patients. And finally, quality control and implementation of quality control is important when looking at these assays, when implementing these different assays. Now, once you have the TDM results, of course, the next thing is to adjust the dose. And there have been a number of strategies that are available. Now, the most simple thing is to just, of course, compare the value you have with a target range. This is the most widely used strategy. It's very simple, but not very accurate, not very refined, and the results are often questionable. An alternative strategy is the use of nomograms, which allow you already to incorporate an additional parameter. Could be weight, could be creatinine clearance. But the most powerful strategy, of course, is to use dosing software. This not only allows you to adjust the dose in a more reliable way, but also make a number of calculations for the first dose, for instance, and allows you to use just one sample to determine a PK profile of the patients. Now, before going into detail in the different recommendations, I do want to stop for a few minutes and focus on the minimal inhibitory concentration. It's a very important parameter. As you will see, many of the PK/PD indices incorporate the MIC. It's often the denominator. But there are a number of issues, and we should be very careful when using this MIC value. Now, the MIC, it's essentially a simple thing. It's the concentration of a drug that prevents visible growth. Now, it's important to realize that for the determination of the MIC, the lab will use a standardized medium at a preset temperature range for 34 to 37, standardized inoculum for only a limited amount of time, so 18 hours typically, not days. So anything that happens beyond 18 hours is not readily reflected in the MIC. So this is how it looks like. You can see different test tubes with different concentration of antibiotics. Dilutions go from left to the right. And within these test tubes, an inoculum is inoculated. And you can see that when the test tube turns turbid, this means that there is bacterial growth. In this situation, this assay, the green tube, the last dilution that is inhibitory is 1 out of 8. So this is the MIC for this specific pathogen. So it's important to realize, however, that this inoculum is 10 to the 5th, and visible growth only starts at 10 to the 7th, 10 to the 8th. So anything in between these values, actually, there may be growth, but it will not be reflected in your MIC. And apart from that, there's a number of other methodological problems. I cannot go into detail, but the bottom line is that it's challenging to use this absolute number and translate it to clinical situations. It is, however, a measure of the antibiotic versus the pathogen, but be very careful to use it as an absolute value. This is two figures from this really very important paper that everybody who's working on TDM should read. Johan Mouton and colleagues actually proposed this strategy to solve the MIC issue. So for wild-type susceptible pathogens, the target MIC should be the epidemiological cutoff. That's quite straightforward and actually incorporates a number of the shortcomings of the test, as I just explained. For the less susceptible, for the intermediate pathogens, it's probably wiser not to use for the epidemiological cutoff, but the target MIC plus twofold dilutions higher. So you would aim higher in order to compensate for the methodological issues that I've just discussed. Now let's go back to the position paper. Which antimicrobials were covered? There are a number of antibacterials that were covered. Aminoglycosides, of course, beta-lactams, glycopeptides, linezolid, polymyxins, quinolone, daptomycin, and cotrimoxazole. That were the different antibacterials that we found evidence on, a number of antifungals, as well as a number of antivirals. And you will see that this document provides you with a lot of information on the individual antibiotics, but also very interesting summarizing tables like this one. And I'll go through this table with you. So this is an overview of the different PK/PD indices and the targets that are associated with clinical efficacy, and toxicity. So on the left-hand side, you can see the different antibacterial classes. The next column lists the PK/PD index of choice for this specific antibacterial. The next table gives you the PK/PD targets for efficacy based on the preclinical evidence. So this is what we've found in lab experiments, whereas the next table provides you with the target for efficacy, clinical efficacy. And as you will see in the different tables, there can be differences, and typically these clinical PK/PD targets will be a little bit higher. The final table gives you the thresholds for toxicity, because it's very important As I mentioned before, it's not only about looking at efficacy, it's equally important to consider toxicity in these for these different drugs. So for every individual antibiotic, in the position paper, you will read about pharmacokinetics, pharmacodynamics, dosing, how TDM should be used, and some recommendations about the assays. Of course, in 20 minutes, it's impossible for me to go through all these individual data, but I recommend you to have a look at the guidance document and read the information there. What I do want to share with you is the recommendations that the panel actually formulated for these three different classes of antibiotics. Aminoglycosides first, it is recommended to either use an AUC-based TDM strategy or a Cmax over MIC-based monitoring. So for the first one, of course, you'll need dosing software and multiple samples for the maximum concentration. Over the MIC, you only need a single sample. The minimal concentration monitoring is important for toxicity, of course. For beta-lactam antibiotics, it depends on the mode of administration. If you use intermittent infusion, then the minimal concentration monitoring is recommended to make sure you have a concentration above the MIC for 100% of the time of exposure. Whereas for continuous infusion, of course, the steady state should be higher than the MIC. There's a lot of debate ongoing whether it should be one or multiple times the MIC. For glycopeptides, using different recommendations according to different drugs. For teicoplanin, concentration, the minimal concentration should be above 15 to 30 milligrams per liter. And for vancomycin, if you use an intermittent infusion strategy, the minimal concentration above 10, a little bit higher for severe infections, or a steady state concentrations between 20 and 25, again, probably aiming a little bit higher for severe infections. For linezolid, the recommendation is to aim for minimum concentrations between 2 and 7 milligrams per liter, both for toxicity and efficacy. And for voriconazole, the recommendation is to aim for a minimal concentration between 2 and 6 milligrams per liter. There's a lot of drugs that I didn't mention here, and this is because the panel was unable to either recommend or discourage TDM. Again, this doesn't mean that it's not reasonable to do it, but the clinical evidence at this point is not strong enough to make a recommendation. There are, of course, many areas for future research. So if you're a junior researcher and you're looking for a topic to investigate, well, antimicrobial TDM in the critically ill patient is definitely an interesting area. We need to know more about the optimal exposure for specific patient populations, such as patients with sepsis and septic shock, the more severe patients. Maybe they need different targets. A very important other thing, of course, is antimicrobial resistance and how we can aim to reduce antimicrobial resistance. And probably, possibly, we may need different targets to suppress resistance. Also looking for different markers, new markers, surrogate markers of antimicrobial efficacy is, of course, important. Biomarkers could be very interesting. The relation between plasma and target site concentration is uncharted domain for many infections. And also the role of TDM in the personalized dosing approach. Again, incorporating stewardship as a general principle. It's not only about measuring the concentrations after you've been administering it for a few days. It's also looking at the first dose and how you can adapt that dose. And finally, the tools for TDM, both assays and dosing software, are also areas to explore further. So of course we have to be realistic, and antimicrobial TDM in the ICU often makes me think of this car. It's a brand new, shiny, fast thing that probably all of us would like to drive. Maybe some of you are actually driving it, so that's another thing. But the thing is, of course, if you don't know how to drive this car, you'll probably crash it after a few kilometers. And the same holds true for TDM. If you don't know how to use it, you probably may end up doing more harm than actually doing any good. And of course, we hope that this guidance document will help you to take better care of your patients. So in conclusion, ladies and gentlemen, inappropriate and suboptimal antimicrobial use is unacceptably high. That's absolutely true. And I think this international position paper summarizes the knowledge on antimicrobial TDM and how it can improve this inappropriate use of antimicrobials. It has a clear rationale for antimicrobial TDM, so it goes without saying that indeed this is a right strategy. And it also summarizes the different advances that have been made both in terms of assays and our understanding of important aspects such as the MIC. Now, while it will give you a complete overview of the different ways you can use TDM of these antimicrobials in your ICU today, again, I do want to emphasize that TDM is not a standalone tool. It should be considered only as an integral part of antimicrobial stewardship. And that, of course, also means that TDM is a multidisciplinary approach and should be embedded in an antimicrobial stewardship program. So thank you for your attention. It was a pleasure being here, and I'll be happy to take any questions later.